Good afternoon, everyone. My name is Jenny Stang, and I am the Caregiver Outreach Specialist for Alabama Lifespan Respite. And my job basically is getting out into the community, letting them know about Alabama Lifespan Respite and the resources we provide, as well as offering education to our caregivers, whether that's a family caregiver, and sometimes we'll get professional caregivers jump on. And my goal as an educator is really to kind of demystify some of the diagnoses that our families have. And also give our caregivers kind of like a lifeline to stress management, a lot of mental health kind of education, and tips on how to really just be the best caregivers they can be. And so when Ashley invited me to participate in your training today, I was very excited because I was doing a crash course series, going through the list of our most common diagnoses of our families. And the ones that she wanted me to talk about were the ones I was already talking about. So it was really perfect timing for us. So today I'm going to go over three diagnoses. One is epilepsy. The second one is Down syndrome. And lastly, we're going to talk about autism spectrum disorder. And my goal with this training today isn't to give you a super in-depth medical type of education, but really just more on the behaviors and maybe demystifying or debunking some myths about the disorders. And I really hope by the end of this, you'll have a more confident outlook on your volunteering. And maybe some of the behaviors we go over today will help you to not be so maybe caught off guard. If you see them, you kind of know what you're going to expect. Know what to expect when starting this respite. So, and again, thank you so much for volunteering. This means a lot to our families. One of the main questions we get as a caregiver outreach specialist is, where do I find respite? So anytime we can help create or expand respite programs in the community, we're going to be all over it because that's what our caregivers need. So let me go ahead and just click on what our agenda is for today. We're going to talk about epilepsy, and in that we're going to define different types of seizures. We're going to define what seizures are. We're going to talk about the causes of epilepsy, and then we're going to go over some first aid protocols and some myths. Secondly, we're going to talk about Down syndrome. We're going to define it. We're going to talk about preferred language, and then we're also going to address some common myths with Down syndrome. And then finally, which is where we're probably going to spend the majority of our time, is with autism spectrum disorder. We're going to define it. We're going to debunk some myths. And then we're going to talk about autistic behavior versus misbehavior. And then we're going to kind of zero in a little bit on autistic meltdowns. Okay. So first and foremost, I just want to let everyone know that I'm a researcher. My background is in social work. I am not a licensed medical professional, and any information that I present here today is for educational purposes only and should not be used to treat or diagnose any illnesses, nor act as a substitute for professional medical or therapeutic care, okay? I can answer questions as far as a research perspective is concerned or a curating of that research. But any specific medical questions, I would just ask that you, ask somebody who knows more than I do, because I only know what I know. Okay. So let's go ahead and begin with epilepsy. And we're going to talk about what are seizures. So seizures involve sudden, temporary bursts of electrical activity in the brain that change or disrupt the way a message is sent between the brain cells. These electrical bursts can cause involuntary changes in body movement or function, sensation, behavior, or awareness. So if you've ever seen anyone have a seizure, you can kind of picture what that looks like, right? Sometimes it's tremors, sometimes they're chewing, sometimes their eye movement's a little different, and that's what a seizure is. So every brain has the potential to seize. It's just if you have a seizure disorder or epilepsy, your threshold for that is a little lower than everybody else's. So that just means you're more likely to have a seizure than people, they're more likely to have seizures than people without epilepsy. And so it's important to know the difference between seizures and epilepsy. So a seizure is an event and can be a symptom of another medical problem. But if you have a seizure, that doesn't mean necessarily that you have an epilepsy diagnosis, okay? Some seizures can be hardly noticed while others are totally disabling. And about half the people who have one seizure without a clear cause will have another one. So if you have a seizure after, say, maybe substance use, withdrawal, maybe a head injury, and you have a seizure then, we know, okay, well, that's what caused the seizure. And so you probably won't have another one unless, of course, that event takes place again. But if you have a seizure where there's no seen cause for it, you're probably more than likely going to have one, and you'll probably be considered for maybe a diagnosis of a seizure disorder. So if there is a known cause for if there's a known cause for your seizures, you're twice as likely to have another one. And seizures are not contagious. So if you have someone in your care who is experiencing a seizure, don't worry, it's not going to jump to you somehow. Okay. So we're going to go over some seizure types. Now, you don't have to remember all of these. I did share a handout with Ashley that had these listed, I believe. If not, I'll get you one. But the goal with me explaining these seizure types to you is so that way, if you do have someone in your care, you know what a seizure looks like, okay? And so I'll try to go over these fairly quickly. And if I'm going too fast, please let me know. First, we have the generalized onset. This is also known as a grand mal seizure. This is the one that I'm the most familiar with as far as, people saying, oh, they had a grand mal seizure. That's kind of what you hear more often. And this will look like convulsions, rigid muscles, so like tense muscles, jerking, and this will typically last between 1 and 3 minutes. And typically the person afterwards is going to be confused for a period of time. Next, we have the generalized onset, which is the petit mal, and that will look like a blank stare that only is going to last for a few seconds. And sometimes they'll be blinking and sometimes they'll be chewing during the seizure. Next, we have focal onset, which is impaired awareness and complex partial. And so what that means is the person is not aware of what's going on during the seizure, and they probably won't remember what's happening during the seizure. And that'll look like a staring or dazed facial expression, and they might perform repetitive or random movements, and they might not be able to talk normally. And typically these will only last 1 to 2 minutes, and those will also be followed by confusion typically. Next, we have the focal onset, and this is called aware or simple partial. And that will be jerking in one or more parts of the body or sensory or perceptual changes that may or may not be obvious to onlookers. So there's going to be things that the person is experiencing that other people might not notice, okay? But during this particular seizure, the person is aware of what is occurring during the seizure. So you could ask them, do you know what happened? And they'll remember most of it, if not all of it. Next is the atonic or drop attacks. I think these would probably be the one that is maybe a little more scary, just because the person will just have a sudden collapse and then they'll recover within a minute. And the reason why I say this might be a little more scary is because if someone's just suddenly dropping, they have a risk of hurting themselves, right? They could hit their head, they could, maybe hurt a limb or fall into somebody. And so that would be one that would just kind of suddenly happen with no prior warning signs. Next, we have the myoclonic seizure, and that is a sudden, brief, massive jerks, involving all or parts of the body. And I think this is probably the one that we see portrayed in the media more often, where a person just has, like a full body spasm. That's the myoclonic seizure. Next is the tonic seizure, and that is sudden, stiff, or tense body, arms, or legs. The person might fall during this seizure, but this will only last around 20 seconds. And then finally, we have the epileptic spasms, also known as infantile spasms. And these are going to be brief 1 to 3 second events of arm, leg, and head pulling, either into or extending from the body. And this will often happen in clusters every 5 to 10 minutes. Or 5 to 10 seconds, over a 5 to 10 minute period. So as you can see, a lot of these seizures have many similarities, and most of them only last for a few moments, okay? So if you see someone seizing, just know that it's not gonna last very long, okay? And if it does, I'll talk to you about why that's important to know how long it lasts. So now we know what seizures are. What's epilepsy? Well, epilepsy is a neurological disease. So someone with epilepsy is at a higher risk for having recurrent or more seizures than the average person. Sometimes people will use the word seizure disorder to describe epilepsy. So if they're saying seizure disorder or they're saying epilepsy, they're talking about the same thing. A diagnosis of epilepsy doesn't define the cause or the outlook. And epilepsy is a spectrum disorder, right? So you can't say I have epilepsy and then every medical professional is going to know exactly what type of seizures you have, what your triggers are, okay? It's a spectrum disorder, meaning that there are variations within the diagnoses. So not one size does not fit all, okay? The impact of epilepsy on a person will vary depending on the type, frequency, and severity of seizures, the areas of the brain that are affected during the seizure, what's causing the epilepsy, which we'll go over that here next, how a person responds to treatment. So are they taking anti-seizure medications? Are they responding well to those? And any underlying brain or abnormalities that may be present, okay? So you don't need to remember all of this, obviously, when you're taking care of young ones during the respite program. But I think the more we know, it's, I always say education is the best tool we have to cultivate compassion. And so the better we understand what's going on with somebody, the better equipped we are to assist them in a compassionate and empathetic way, okay? So what causes epilepsy? I was surprised when I did my research for this because I really did think epilepsy was just something you were born with. I didn't know that it was something that can develop later on in your life, and it absolutely can. So we have head injury is the main cause of epilepsy. So that would be previous falls, concussions, really any injury to your head cause epilepsy. So obviously we want to take precaution during activities like riding a bike or skiing or riding a motorcycle to protect our head against injury. And if you are of my generation or younger, you probably remember never having to wear a bicycle helmet when you rode your bike. We didn't even have seatbelts back in those days. So we've come a long way as far as like preventing head injuries, which, you know, I'm grateful for definitely. So a head injury can lead to an epilepsy diagnosis. Next, we have brain infections. So infections like meningitis, they'll inflame the brain and the spinal cord, and they can increase your risk for developing epilepsy. Next, we have stroke or vascular disease. So that's where the blood vessel disease or diseased, or they're having a stroke, or that kind of stuff. It can cause brain damage. And so damage to any area of the brain might trigger seizures and eventually epilepsy. So the best way to prevent epilepsy caused by vascular disease is to just take care of your heart, right? Take care of your heart and your blood vessels with healthy diet and regular exercise. And of course, avoiding tobacco use or excessive alcohol consumption. Next, we have dementia. So people experiencing a decline in their mental function might also develop epilepsy. It's most common in older adults, obviously. You're not going to have an 8-year-old with dementia-related epilepsy. So that's something that our older loved ones may experience. If they never had that experience before, if they have dementia or Alzheimer's disease, they could develop epilepsy. Next, genetic factors. So if a close family member has epilepsy, you're more likely to develop the disorder as well. So children with parents who have epilepsy have a 5% risk of developing the disease themselves. So it can be hereditary depending on, you know, if you're genetically predispositioned to epilepsy. So some children will develop epilepsy as a result of their brain being injured in some way. And this could be due to severe head injury, like we said, difficulties at birth, infections in the brain, like meningitis, like we said. And so this type of structural change is sometimes called symptomatic epilepsy. So that would be an epilepsy that that you kind of have, sorry, I lost my train of thought, where you have a distinct cause for the epilepsy. It's not just genetic, okay? And then if you have a brain tumor, obviously that can affect the structural makeup of your brain. And then sometimes there's just a malformation in the brain in utero, right? So it's just some people are born with epilepsy. They do not develop it later on in life. All right, so now we're going to get into the nitty gritty of epilepsy, which is first aid protocol. So this is probably where you're going to want to take, I think I did pull all of these in the handout. If you want to take notes, that's great. And if you need more information from me, I'm more than happy to send it to you. But I think it's important that we debunk some first aid myths that we've, maybe just picked up in our lifetime about epilepsy, because they can be very harmful to somebody experiencing a seizure. So let's go ahead and debunk that. The common myth number one is that people can swallow their tongue during a seizure. I know when I was growing up, that's what I heard. Everybody, oh, they're going to swallow their tongue if they have a seizure. But that is physically impossible for someone to do that, whether or not they're having a seizure. Next, common myth number two, When someone's having a seizure, you put something in their mouth. I've heard this one too growing up because you're like, well, you don't want them to bite off their tongue or you don't want them to bite their cheek and hurt themselves. In theory, that makes a lot of sense, right? But in practice, that can be incredibly dangerous. So we should never force any object into someone's mouth during a seizure. That could cause injury to the person, and it could also cause injury to you, right? They can bite your hand during that process. They're not in control, and our jaws can be pretty strong, so you might want to stay clear from that. And also the person could swallow whatever you're trying to put in their mouth to protect them. So while you're well-meaning, it could actually make things a lot worse, so we don't want to do that. And then finally, number 3, you should restrain someone who's having a seizure. I think it's just kind of maybe our first reaction is if somebody is, moving in a way that possibly could harm them, that you want to like hold them still so that they don't hurt themselves. But we don't want to restrain someone who's having a seizure. But you can take precautions to make sure that they're in a safe place, right? So you can move furniture out of the way, moving sharp objects, placing something soft under their head. And if you see somebody in a seizure or, whether it's a big one or a little one or whatever, you notice that they're having a seizure and they are starting to fall, you can support them as they fall, okay? But you don't want to restrain them, okay? So what do we do during a seizure? Well, understanding what to do when a seizure occurs obviously is crucial for ensuring their safety and anyone else who's around them. You don't want anyone to hurt themselves, and so seizure first aid is pretty simple, and in most cases, you won't even have to call an ambulance. So again, you're going to think about how long is the seizure lasting. So we want to time it, because how long the seizure lasts will determine whether or not you need to call an ambulance. Cushion their head. So head injuries are very common during seizures, especially when there's hard floors or objects that can cause harm. Next, we want to roll the person into recovery position. So to prevent choking, we want to roll them on their side if they have something in their mouth or after they stop moving. Okay, so if someone's seizing and they've got something in their mouth, say they're chewing gum or whatever the case, we want to kind of roll them to their side so that way nothing's getting gravity's not doing its job and lodging anything way back in their throat. Okay, and then once they've completed the seizure, if they've not, if you haven't had to roll them over before, once they're done with the seizure, you can roll them to that recovery position just to kind of help acclimate them a little bit better. And then we want to stay with them until the seizure stops. So the person might be confused, they might be disoriented afterwards. And so you want to help them remain calm and safe, especially if it's a child. Most kids are very resilient, but I would imagine having a seizure, even for a little one who's maybe used to it, could still be very disorienting. And it's good to have that person there, that calming presence to let them know that they're safe and they're not alone. So there are some times where you have to call 911 for a seizure. And that will happen if the seizure is lasting longer than 5 minutes. If you remember when we went through all the different types of seizures, most of them were only 1 to 2 minutes. So if you have a seizure, and of course, if you're thinking about the infant spasms that happen in 5 to 10 minute stretches, but in 5 to 10 second intervals, that's a little different. But if they're having a complete seizure with no breaks for 5 minutes, you need to call 911. If the person is experiencing any difficulty breathing, regardless of how long the seizure is lasting, if you can tell that they're not having adequate air circulation, you need to call 911. If they're having a seizure that takes place in water, that can be very dangerous because, you can breathe that water into your lungs, right? If you're having a seizure and they lose control, they could drop underwater. So you want to make sure the ambulance is there to check them out, make sure they're okay. And then, of course, if there's any injury during a seizure, so if anyone's had any trauma to the head specifically, we want to call 911 and make sure they're okay. But in most cases, you won't have to call an ambulance, and it'll only last a few minutes. You want to document information about the seizure, not only for your own records, for the agency or the program, but also for the guardian and their medical professional. So we want to know what happened right before the seizure. Were there any identifiable triggers that we can think of? The date and the time the seizure happened, how long the seizure lasted, and the behavior of the person following the seizure. Were they disoriented? Were they confused? Were they fully aware? Were they okay? Okay, just document that, keep track of it. And of course, we want to defer to the child's guardian and the program policies when responding to seizures, because like I said, this is an educational thing. It's not instructional. And so whatever policies that are in place for your program, defer to those. All right. Are there any questions about epilepsy before I move on? Okie dokie, artichoke. Let's move on to Down syndrome. So we're going to define Down syndrome, and we're going to spend some time about the preferred language guide. It's going to be kind of just a brief overview on just, common courtesies with people who have Down syndrome. And then we're going to address some of the common myths surrounding Down syndrome. So what is Down syndrome? So in every cell in the human body, there's a nucleus where genetic material is stored in genes. Sound like sixth grade biology yet? So the genes carry the codes responsible for all of our inherited traits and are grouped along rod-like structures called chromosomes. So typically, the nucleus of each cell will contain 23 pairs of chromosomes, half from one parent, half from the other. And Down syndrome occurs when an individual has a full or partial extra copy of chromosome 21. So that additional genetic material will alter the course of development and causes the characteristics associated with Down syndrome. So there are 3 types of Down syndrome. One is called the trisomy or trisomy 21. I'm not sure how you actually pronounce that, so I apologize if I'm saying it wrong. And this is usually caused by an error in the cell division called non-disjunction. And non-disjunction results in an embryo with 3 copies of chromosome 21 instead of the usual 2. So that could be a full or a partial copy. So prior to conception, a pair of the 21st chromosomes in either the sperm or the egg will fail to separate. And as the embryo develops, the extra chromosome is then replicated in every cell of the body. And so this type of Down syndrome actually accounts for 95% of all cases in Down syndrome. So an individual that comes into your care will more than likely have this type of Down syndrome. But there's 2 other kinds. There's one called the mosaicism or mosaic Down syndrome. And that's diagnosed when there's a mixture of 2 types of cells. Some containing the usual 46 chromosomes and some containing 47. So the cells with 47 chromosomes contain the extra chromosome 21. It is the least common form of Down syndrome, and it accounts for only about 2% of all cases. Research has indicated that individuals with mosaic Down syndrome may have fewer characteristics of the Down syndrome that we're more familiar with. However, broad generalizations obviously aren't possible because there's a wide range of abilities with people in Down syndrome or with Down syndrome that they possess. So we can't really speak in generalizations. And then finally, we've got translocation. And translocation accounts for about 3% of the cases of Down syndrome. And the total number of chromosomes in the cell remains 46. However, an additional full or partial copy of chromosome 21 will attach to another chromosome, usually chromosome 14. And the presence of the extra or full partial chromosome causes the characteristics of Down syndrome. So regardless of the type of Down syndrome a person might have, all people with Down syndrome have an extra critical portion of chromosome 21 present in all or some of their cells. Okay, so that's why they're all considered Down syndrome, because they are all affecting chromosome 21. So people with Down syndrome can have a variety of additional complications that are kind of prominent and they become more prominent as they get older. And so those complications can be heart defects, gastrointestinal or GI defects, immune disorders, sleep apnea, obesity, spinal problems, leukemia, and dementia. Down syndrome might also be associated with other health conditions, including endocrine problems, dental problems, seizures, ear infections, and hearing and vision problems. So I tell you this so that you can be sure to ask the caregiver or the guardian of the child that's coming into your care about any additional health needs that they might have. So that way, if there's any steps you need to take, you're fully prepared to do so. So we want to go over preferred language. Words matter, and how we talk sets the tone for our interactions with families and individuals with Down syndrome. And so we want to take the extra care and the extra time to address our friends appropriately, okay? And families and individuals with Down syndrome really appreciate this, as it shows respect for the individual. And so we want to use person-first language. And the reason why is because it shows that a medical condition or a genetic syndrome, it's not defining the person. And it's simply one or part of the whole person that they are. Okay, so if we use the diagnosis first, we're labeling them as the diagnosis before we're labeling them as a person. Okay, so it's just a better way to communicate with each other. And also, families don't want to hear sorry when they talk about their child with Down syndrome. Most, if not all, families that I've met are not sorry that they have a child with Down syndrome. They're proud of them. They're proud of what they accomplished. And so sympathy really isn't the way that you want to lead into a conversation with somebody, okay? So here we go. Use this language when referring to Down syndrome and people who have Down syndrome. People with Down syndrome should always refer to as people first. Instead of saying Down syndrome child, it should be a child with Down syndrome. See the difference? Also, we want to avoid saying Downs child, describing the condition as Downs, as in he has Downs. Okay, that's an older version of the way we communicate about it, and we don't say that anymore. Down syndrome is a condition or a syndrome, and it's not a disease. And people have Down syndrome, they do not suffer from it, and they're not afflicted by it. Okay, we use the words typical or typically developing in preference to normal. So we don't want to say, well, that's a normal child. We say that is a typical child, or that is a typically developing child. Okay. Intellectual disability or cognitive disability has replaced the term mental retardation as the appropriate term. And so I really want to drive this home. I'm sure many of you are already aware, but just in case you are not, the National Down Syndrome Society, as well as Alabama Lifespan Respite, will strongly condemn the use of the word retarded in any derogatory context. Using this word is hurtful and suggests that people with disabilities are not competent. So that word is actually, an older term that was used in the medical profession, but then it kind of morphed into a slur. And so we definitely don't want to use slurs or negative connotations or anything derogatory when talking about someone with Down syndrome or any other diagnoses for that matter. Okay. Down versus Downs. So we don't want to use Downs syndrome with the apostrophe S. The preferred spelling is Down syndrome. So Down syndrome is named for the English physician John Langdon Down, who characterized the condition, but he did not have it. So whenever we use an apostrophe S, obviously that connotes ownership or possession. So while Down syndrome is listed in many dictionaries with both the popular spellings with or without the apostrophe S, the preferred usage in the United States is Down syndrome. Okay. So we're going to address some common myths now. Again, the goal here is to build empathy and compassion, and we don't want to make stereotypical comments or have stereotypical beliefs about people when we're meeting them, okay? So the first myth we're going to address is adults with Down syndrome are the same as children with Down syndrome. I've seen this in real life. I've seen it in the media. I don't know why, but people like to infantilize people with Down syndrome or autism spectrum disorder or any, visible disability. And I'm not sure why people do that, but it's very disrespectful. So adults with Down syndrome are not children and should not be considered children. They enjoy activities and companionship with other adults and have similar needs and feelings as their typical peers. Okay. Next, people with Down syndrome are always happy. Well, the truth is, people with Down syndrome have feelings just like everybody else. They experience the full range of emotions and they respond to positive expressions of friendship, and they're hurt and upset by inconsiderate behavior, just like everybody else. Okay. Next, all people with Down syndrome have severe cognitive disabilities. Well, the truth is, most people with Down syndrome have mild to moderate cognitive disabilities or intellectual disabilities, but it is not indicative of the many strengths and talents that each individual possess. So be considerate of the extra time it might take for a person who has a disability to get things done or said, okay? There are many, like I said, it's a spectrum, right? So many people who have Down syndrome, they have very mild cognitive disabilities. And then there's others who have more moderate cognitive disabilities. So we really can't say all people with Down syndrome behave this way or have this disability or have this severity, okay? Because people with Down syndrome are individuals, right? Just like everybody else. And so we can't just assume that they have a limited, severe limited cognitive disability, okay? The next myths we're going to discuss: people who have Down syndrome don't feel pain. This was new to me. I didn't know this was a myth, and I thought it was a very strange thing for people to think that they couldn't feel pain, but apparently that's a myth. People with Down syndrome absolutely feel pain, although the reaction is not always apparent. So there was a 2000 study published in a medical journal called Lancet that suggests that such individuals express pain more slowly and less precisely than a typical person, but that doesn't mean they don't feel the pain. So people with Down syndrome may be given the same types of pain control procedures as a typical person, even in the absence of obvious signs of pain. Okay, so if you have somebody who's injured themselves and they have Down syndrome, address their pain. Okay, address their pain. Next, people with Down syndrome all look alike. Well, the truth is, many, but not all people with Down syndrome do share common features. For example, many, but not all people with Down syndrome have almond-shaped eyes and a shorter stature. However, like typical people who share similar features, they look more like their families than they do look like each other. Okay. And finally, people with Down syndrome can't go to regular public schools. Well, the truth is, it's not only advisable that children with Down syndrome attend their public schools, but the US requires that by law, public schools have to accept and provide appropriate education. And further studies show that including students with disabilities in the classroom improves the academic progress of students without disabilities. So the more diverse our classrooms are, the better it is for everybody involved, whether they're typical or not typical. Are there any questions on Down syndrome before I move on? Right. Now we're going to talk about autism. So autism spectrum disorder, we're going to talk about what is it, myths and misconceptions again. We're going to talk about autistic behavior versus misbehavior. And then we're going to talk about autistic meltdowns. So what is autism spectrum disorder? Also known as ASD. So if you hear me say ASD, it's just the abbreviation for autism spectrum disorder. That is a neurological and developmental disorder that affects how people interact with others, how they communicate, learn, and behave. So although autism can be diagnosed at any age, it's described as a developmental disorder because the symptoms are generally appearing within the first 2 years of life. Autism is known as a spectrum disorder because there's a wide variation in the type and severity of symptoms that people experience. So maybe you've heard the terms high functioning or high needs or low needs, things like that. That's just because it's a spectrum. So again, one size does not fit all. So people of all genders, all races, all ethnicities, all economic backgrounds can be diagnosed with ASD. It does not discriminate. And although ASD can be a lifelong disorder, there are treatments and services that can improve a person's symptoms and daily functioning, okay? So if you have a loved one who has autism spectrum disorder, they're probably in several different types of therapies to kind of address their specific needs on the spectrum. And so that's very common for people to see more than one specialist when they have ASD. So what are some myths? The first myth we're going to address is that the appearance of autism is relatively new. I'll hear a lot of people in older generations say, well, they didn't have this when I was younger. Yeah, we did. We just didn't have a name for it, right? Or we didn't have the exposure to it that we have now. So the truth is that autism was first described by a scientist named Leo Cranner in 1943. But the earliest description of a child now known to have autism was written all the way back in 1799. Ongoing research and improvements in diagnoses have identified that the characteristics of autism exist on a continuum with varying degrees of severity, intensity, and frequency. So the CDC estimated, and this is from a 2014 study, so it might be different now, but that's the most up-to-date information I could find. They estimate that 1 in 68 children in the United States have a diagnosis of ASD. So it's fairly common. Next myth is autism is caused by vaccines. This is the big one, right? We heard this, nonstop, pretty much 24/7 back in the day with Jenny McCarty and a couple other celebrities saying that vaccines caused autism. That was based on a 1998 study that has since been retracted. And numerous studies continue to confirm that there is no direct evidence that links vaccines to the development of autism. Okay, so hopefully that closes the chapter on that myth. Next myth is autism is a mental health disorder. The truth is autism is a neurological disorder. Okay, so mental health disorders and neurological disorders symptomatically can have some overlap, but they are different. Studies of people with autism have revealed abnormalities in the way the brain is structured and the levels of neurotransmitters a person has. So, what's commonly overlooked, though, is that individuals with developmental disabilities are twice as likely to have co occurring or comorbid mental health disorders that they also need treatment for. And so that could be why people think that everybody who has autism is experiencing a mental health disorder. But you have to consider too, mental health disorders, they can be biological. You know, it could be something that you're born with. It could be something that you have a hereditary predisposition to, but it could be environmental causes as well. And so if you think of someone who maybe has this diagnosis, who maybe struggles with social things and struggles with communicating with other people, maybe they don't know for a long time they've had autism spectrum disorder, they might develop some of these mental health disorders as a result of the way the culture around them behaves or treats them or accepts or does not accept them. Okay, but that doesn't mean that everyone with autism is going to have a mental health disorder. Okay, next, all individuals with autism have mental disabilities. Again, you're probably trying to see a theme here that we can't say all people, okay, all this, because it's never all everybody, okay? So the truth is individuals on the autism spectrum are unique and they have a wide range of intellectual abilities. Individuals with autism can be harder to test, so IQ and abilities can be under or overestimated unless the testing is done by an expert in intellectual and developmental disabilities or autism. Tests designed to include language and interpersonal analysis, they might misrepresent the intelligence of people with autism who struggle with social skills. But many individuals on the autism spectrum have earned college and graduate degrees. They work in a variety of different professions. And conversely, it is sometimes mistakenly assumed that an individual with autism has a higher level of understanding than they do based on their behavior, language skills, or high level of ability in a specific area, which we'll go over some more of that here in a little bit. The next myth, individuals with autism are violent. Well, the truth is, there may have been some recent reports or news stories relating autism to violence and aggressive acts, but that usually will arise from sensory overload or emotional distress, which we'll talk about again in a little bit. And it's really unusual for individuals with autism to act violently out of malice or to pose any danger to society, just like everybody else, right? The average Joe or Jane isn't out there causing violence and mayhem for no reason, right? It's the same with people with autism. So many individuals with autism actually prefer to limit their exposure and interactions with other people because social situations can feel confusing and they can cause a lot of anxiety. So of course, you know, if you have a lot of anxiety in social situations, you're typically not going to be out there causing problems to make yourself feel more anxious. So next myth is all individuals with autism have savant abilities. The truth is, while there is a higher prevalence of savant abilities among those with autism, it's really only about 10% of individuals with ASD that exhibit savant abilities. But what we do see is some individuals with autism have what we call splinter skills, and that just means skills in one or two areas that are above their overall performance abilities. So they have maybe very distinct interests that they know a lot about something, but that doesn't necessarily put them in the savant category, okay? And next, people with autism can't stand to be touched. So this can be true for some people who have high sensory sensitivities, but many people with autism enjoy hugs, light massage, and other forms of touch, just like everybody else. Next, autism is caused by poor parenting or quote unquote refrigerator mothers. Though the exact cause of autism has not yet been determined, it is now firmly established that development of autism has nothing to do with parenting style. Remember, this is a neurobiological disorder. Okay, this is something that has to do with the way that your brain has formed, your neurotransmitters, all that stuff. It's a pre-birth situation that you're looking at. It's not post-birth. So regardless of your parenting style, it does not cause autism. And the next or last one, people with autism are cold and lack empathetic feelings. Um, I don't have autism, but I have friends with autism, and I really did take personal offense to this. Because if you know anybody with autism, at least in my experience, nothing could be further from the truth. So the truth is, individuals with autism feel as much, if not more, empathy as others, but they may express it in ways that are a little harder to recognize. Okay. Let me go ahead and skip to the next one. Now we're going to talk about autistic behavior versus misbehavior. I think this is important to address, especially if you have, maybe grandparents or people who maybe are not familiar with autism. They may see behaviors in children that are autistic behaviors. They may interpret them as misbehavior. And so I think it's good that we address this so that we know that there is a difference, because we know misbehavior requires a different response than behaviors that they can't control, right? So autistic behaviors are usually a result of a few very specific types of challenges. And because every autistic person is unique, the challenges will look different to each child, but they exist at some level in anyone who's correctly diagnosed with ASD. So the first one we're going to talk about is sensory challenges. So people with autism are almost always likely to either overreact or underreact to sound, light, smell, and touch. So anything that's going to affect the senses. A child who runs away from a grandparent who's trying to give them a hug might actually be responding to the smell of their perfume or cologne, right? They're not trying to run away from grandma. She just smells funny to them, and they're having a reaction to that. The child who hates hugs might dislike the sensation of being squeezed, but they actually feel affection towards the person giving the hug, okay? Remember, it's a sensory processing disorder. So a sensory challenge could be something as minor as a buzzing light, fluorescent lights above that buzz. I don't have autism and it drives me nutty. And I don't have sensory processing disorder. So we can only imagine how people who do, how that would make them feel. And a sensory challenge may also be the reason behind the quote unquote misbehavior. Like if you're in a crowded or loud auditorium or you're squeezed between people standing in line, that can be very problematic for people who have sensory processing issues. So how do we know when a sensory issue is causing the problem? Very simple, we can ask. So if the child is verbal, they might be perfectly capable of explaining behaviors if you ask them. Next, you can watch. So if a child is covering their ears while they're bolting from a room, it's reasonable to assume that something about the room or the sound in the room is causing the problem. So if you've got a little one who maybe isn't verbal, maybe even an older one who's not verbal, but you see them kind of covering their ears or, reacting to a sensation, you can kind of make a good indicator, or if that's a good indicator that something is sensorily challenging to them. And then next, keep tabs on behavior. So if you know your child well enough and you know that they're usually able to handle like a worship service, but on one occasion it becomes loud and they run out of the room, well, we can say, well, that's probably why, right? The sudden sound caused an issue for them. But if the behavior is consistent, there might be an ongoing sensory challenge in the environment. So if your child is always having a hard time in the auditorium, then, especially if you go to like a modern church service where they've got louder music and lights and some of them have smoke machines or whatever, it can be very overwhelming for somebody who has a sensory challenge. All right, and next, social communication challenges. So people with autism have a tough time with social communication on one level or another, and it can be difficult or even impossible to read another person's emotions, or also overreacting to somebody else's feelings. So it can be very tough to watch and imitate another person's behavior. So the fact that other children are sitting still and being quiet, it might not register for a child who has autism. So what are the signs that they're having difficulties with that social communication? We want to notice the child's intent, right? Sometimes they may exhibit behavior that seems malicious or seems nasty, but you can kind of tell, are they intentionally being that way, or are they just having a hard time communicating socially, okay? It can make it hard for a child with autism to tell when their actions are hurtful if they have social communication challenges. So you might have them walking away out of boredom, or a desire to do something different. And that could look kind of mean-spirited from the outside looking in. But there's a very good chance that that child just doesn't recognize how their behavior is likely to affect others. I'll give you a story. My 9-year-old's best friend has autism. And oftentimes, you know, when she gets bored, she's done. She stands up, walks away. That happens all the time. And my daughter was getting her feelings hurt. She's like, you know, why does she always just leave? And I had to explain to her, it has nothing to do with you. She was just done playing that game, you know, and she just wasn't in a space where she could communicate that in the way that you would see a typical child communicate that. Okay. So we got to remember that children with autism have developmental delays. So a neurotypical 12-year-old will behave differently than a 12-year-old with autism. A 12-year-old with autism might seem a little more immature than their neurotypical peers. And so they often do seem immature for their age. And so a teenager may act like a younger child. Cognitively, they're, you know, age appropriate, right? They're developing the way that they're supposed to, but socially they may be more immature. Okay. So we don't want to label that as misbehavior. That's just an autistic behavior. And then next, we want to be aware of how instruction is provided. I think this is a very important key for, you know, engaging with children who have autism. The way that we communicate our intent and our desire for their behavior is got to be very clear. It's got to be very direct. Okay. So let's just say that a teacher says a child is misbehaving at recess by pushing in line or maybe taking extra long on the swings. But children with autism, they rarely learn through imitation. And so you're going to need to give them direct instruction on behavioral expectations. So did the teacher actually tell the child about the rules of recess? Did they provide visual supports or social stories to help aid in that understanding? If not, how are they expected to know the rules? Okay. So they're not going to be observing their environment in the same way that a typical child is going to and be able to pick up on those subtle social cues. So they have to be told directly. We don't push on the swings and we only take turns that last, you know, X amount of minutes. Okay. And then by giving them that instruction, that direct and clear, concise instruction, it's going to eliminate a lot of these quote unquote misbehaviors or what seem like misbehaviors because now they know what the expectation is. Okay. So now we're going to talk about some behavioral challenges that people with autism may experience. Autistic behaviors are usually self-evident because they're generally quite different from neurotypical behaviors. And as a result, you should be able to tell at a glance whether you're seeing misbehavior or traits of autism. So here's what you can look for. Self-stimulation, or also known as stimming. Many people with autism will use physical behaviors such as rocking, pacing, flicking their fingers, humming, and all that is doing is helping them to calm themselves and stay focused. So when you see those behaviors, you can be almost certain that they're not a form of misbehavior. They're not trying to be disruptive. They're not trying to call attention to themselves, and they may not even be aware of how other people are responding, right? They're just trying to calm themselves or focus more, okay? So that's a behavioral challenge they may experience. Next, lack of eye contact. I know my grandmother growing up was very much about, you know, look me in the eye when I'm talking to you because it's not respectful if you look away. Thankfully, the type of parenting is kind of falling to the wayside. But many people with autism, they have a difficult time with eye contact. And for some, it's almost impossible, particularly during a conversation. So you can teach a young person with autism to maintain eye contact, but the lack of it is not a form of misbehavior. There's actually a study out that says avoiding contact is a way for a person with autism to decrease an unpleasant sensation that's caused by an overactivation of a particular part in the brain. So again, it's not that they're trying to be disrespectful. They really just can't tolerate it, right? That's a sensation that they're experiencing and they can't tolerate, so they have to look away. But that doesn't mean they are not paying attention to you. Next, self-abuse. So in some cases, particularly but not exclusively for people with autism who have high support needs, self-abuse can be very common. That can look like banging their head, picking at their skin. Sorry, I lost my train of thought here on my notes here. There we go. So banging their head, picking their skin, And those kind of behaviors are not intentional, though they can be harmful, and so they should be managed. So if you see a young person and they're hurting themselves in some way, we want to know that's not misbehavior, and we want to try to address that and see what's going on and how maybe we can adjust the environment to make them feel more comfortable. Next, lack of focus or attention. People with autism may find it easy to focus on one thing, but tough to focus on others. Often they're paying attention without appearing to do so. So sometimes they're not able to pay attention because they're having a tough time following rapid speech or abstract ideas. And very rarely are they ignoring the speaker. Again, socially, we like to have our children be focused and, looking us in the eye and listening intently. And as much as a child with autism may want to behave in that way, they may not be able to do so. So we can't label that as misbehavior. And then finally, noise making or bolting. Children with autism can make noise or leave the room just to be annoying, like any other child can, but it's highly unlikely that they're doing that for that reason. They probably have other reasons of doing that. So maybe they're screeching, humming, or chattering again to calm themselves down, or maybe they're bolting from a room to get away from a disturbing sensation, right? We think about that example about being in the church again. If maybe a loud moment happens in the worship song, they can't handle it and they take off running. Okay. They're not being disrespectful. They're not misbehaving. They're responding to a sensory overload. So how do we respond to misbehaviors? Well, of course, I'm not going to tell anybody how to parent, and I'm not going to tell anybody how to write policies for your program, but I can give you some guidelines, I guess, as far as handling a true misbehavior from a child who may have autism. So we want to set and communicate limits and expectations. Children with autism may need to learn about limits very directly through instruction, visual tools, or social stories. There are a lot of books on the market now specifically for this that are very useful that I would highly recommend you looking into for your library if you have one, or maybe even just to have around for, for times where you want to learn a little bit more about these types of behaviors and help your young ones kind of understand what your expectations are as well. Next, offer support for improving behavior. And I think this is very useful for children who are typical and non-typical children. Children with autism often need immediate reinforcement for a job well done. And that could be simple as a small treat, a high five, or just a big smile, just something that acknowledges what they are doing is good, right? You want to encourage that type of behavior. Next, notice and respond to good behavior, kind of piggybacks on the same thing we just talked about. It's important to be responsive when a child misbehaves or behaves well, and be very specific about what was good about their actions. So you can say, hey, Johnny, it was wonderful how you shared your toys with your friend this afternoon, right? Just be very specific so that they know that that behavior was good and that you're encouraging that, you're responding in a way that's going to promote better or good behavior. And of course, we want to defer to the guardian of the child and any program policies when responding to misbehaviors, okay? But I think it's important to know what misbehavior looks like in an in a child with autism spectrum disorder, so that way we are not constantly trying to discipline them for things they can't have any control over. So next, we're going to address autistic meltdowns. Autistic meltdowns, they're involuntary, okay? We have to remember these are children and adults who are experiencing the world a little differently than a typical person's experience it. So when we get sensory information in our environment, we process it and we do what we need to do in that environment. A person with autism, they're going to absorb sensory information too, but it's going to be a little different than the typical person. So they're more prone to nervous system overloads because of that sensitivity. So remember, an autistic meltdown is an involuntary response to a nervous system overload. It is a highly dysregulated state. It's not behavioral, but it's a physical manifestation of a neurobiological reaction. So if we see behaviors that maybe look like a tantrum, but the child has autism, we need to go back and think, is this an involuntary response to their environment? Okay, because you don't want to discipline somebody for something they can't control. Again, I've said that 35,000 times, and I'm going to say it 35,000 more because it's very, very important. So an autistic meltdown is bigger, more emotional, longer lasting, and more difficult to manage than a temper tantrum. And temper tantrums and meltdowns have different causes. So a tantrum is typically going to be manipulative. That's when a child tries to get what they want by crying and screaming and making a scene. But by contrast, autistic meltdowns are not manipulative. They are genuine cries of distress. Okay. So if a child is experiencing an autistic meltdown, the last thing you want to do is put them in a timeout or take away their video games or, whatever your punishment is in your home or in your facility. Okay. Because it is not a disciplinary issue and it's not going to do you any good. Okay. So we need to know the early warning signs of a meltdown because that's the best way to prevent them, okay? So prior to a meltdown, a person with autism will often start to show signs of distress. They can be subtle, like biting their nails, or if they're older or verbal, they can ask to leave, or more obvious, like covering their ears with their hands. So it's important to be aware that these behaviors are a response to stress and or sensory overload and not a form of manipulation, okay? So in young children, an autistic meltdown could look much like a temper tantrum, but it's just more intense. And but they're not limited to just younger children. Older children, teens, and adults with autism can also experience meltdowns, and even those who have low support needs or are considered high functioning. Okay. So a meltdown occurs when the brain goes into fight, flight, or freeze response due to overwhelming emotions. So it's almost like a trauma response. It's an involuntary reaction and it can't be controlled by the person experiencing the meltdown. Autistic meltdowns will often last at least 20 minutes after the initial trigger is removed. Okay. So if a child is having an autistic meltdown that's triggered by fluorescent lights buzzing, you can remove them from that room and it will still take at least 20 minutes to calm them down. Okay. So if you think, well, this is the trigger, maybe their socks were goofy and, it's causing a sensation or whatever the case may be, you fix that trigger and they're still experiencing the meltdown, just stay the course because it'll take them a little while to calm down. Okay. That doesn't mean you did anything wrong. It just means time has to pass. Okay. And after a meltdown, it can take a while for that person to recover. So allowing them time and space to regain their emotional regulation is crucial. They're often unable to recall the details of what happened. And so we don't want to try to discuss that within, the following hours of the meltdown because they might not be aware of the behaviors and it might still be taking them a while to regulate. So of course, an autistic meltdown will vary in intensity and in behavior depending on the person. But some of them might include biting, crying, destroying property, foot stomping, hitting, kicking, vocal outbursts like yelling, name calling, sobbing, or intense screaming, self-injury such as banging your head, hitting themselves, or banging their head, hitting themselves, or pulling their own hair, stimming, again, throwing and breaking objects, running off, or just zoning out, like disassociating, okay? So again, a lot of these behaviors mimic a tantrum, but we have to be aware of the motive, okay? A motive of a tantrum is manipulation, and an autistic meltdown really doesn't have a motive. It's just a reaction that they're having, okay? So disciplining someone for experiencing an autistic meltdown would be the same as disciplining someone because they burn themselves on the stove and it hurts, okay? They have no control of the way their body's responding to that stimuli, okay? So how do we prevent autistic meltdowns? That's the key. They can be prevented by identifying triggers and recognizing the warning signs. So this might be something that you could include maybe in your intake paperwork or your sign-up paperwork, whatever you call it, with your parents. Have them tell you what are some triggers that your child experiences, what are some sensitivities that they have, so that way you're prepared and you know what to look for, okay? So once the situation rises to that of a meltdown level, it's very difficult for the person to calm down. So we want to avoid getting to that level as much as we can. So we want to recognize triggers. So sensory overload is a common meltdown trigger. That can include lights, sounds, smells, and different textures, like a seam in a sock. And that can cause emotional overwhelm with the person who has autism. And that stress can trigger a meltdown. So if you know the child's triggers, you can find ways to avoid them or make them more manageable, okay? Next, heed the warnings, okay? So if you see the warning signs, make sure you act, okay? Keep an eye out for subtle signs of overwhelm and take action to eliminate the cause or move the child to a calmer space. So signs of building distress include anxiety, irritability, and stimming behaviors. Older children might be able to verbalize that they're getting overwhelmed. So whenever you see these signs or if they point it out to you, take action. So for example, a child who's overwhelmed by noise and light, they might calm down quickly when you take them to a quieter and more dim place, okay? And a child who's anxious about a social situation, they may need clear direction, reassurance, and support. If an intervention doesn't occur or it doesn't solve the problem, a meltdown's almost inevitable, and that person will become overwhelmed by their emotions. So it's very key for you to be aware of what's going on in their environment so that you can take action as quickly as possible. When a full meltdown is in progress, it can be hard to manage. The best way to help someone during an autistic meltdown is for you to remain calm. That's how we co-regulate another person. They kind of pick up on our calmness. It provides a safe, calming presence. And each person with autism is unique, and there's no one technique that will help everyone. But however you respond, just always lead with kindness and empathy. Okay. I think that's good advice regardless of the situation, to always lead with kindness and empathy. So, of course, your guardians and your program policy will have instructions on how you handle an autistic meltdown or how you help a person calm down. But here are some suggestions. Try calming music, a cold drink, compression, cozy blanket, deep breathing is a good one. Dimming the lights if that's what's causing the distress, maybe even distract them from what they're distressed about. Empathy and kindness, there we go again, my two best friends. Maybe they have a favorite stuffed animal that they brought along with them. That would be a great idea. Fresh air, pressure, so like maybe a weighted blanket if they're older. Maybe let them punch a pillow. I know that makes me feel better. Rubbing their back if touch is appropriate. Maybe just being in silence. Skin brushing, they have these really soft bristle brushes that can be very calming. So that might be something that they could use. Different textures that are soft, maybe things that are appealing to the child, especially if they're having like a touch sensory issue. Tight hugs, and again, weighted blankets. Are there any questions about autism spectrum disorder?
It's not looking like it. Does anybody have any questions?
So thank you so much. That's the end of my information today. If there's any questions or comments about any of the information I presented today, I'm more than happy to take that and answer it as best of my ability. And I can also share with you my sources if you guys want to do a little bit more research on your own, or if there's some things that maybe you're curious about that I didn't cover. There's a ton of information online. I would just encourage you to make sure you go to specific foundations. Anything that's got a .gov is going to be good. I know there's a lot of blogs and things like that, personal things that people have on the internet that do have a lot of good information. I would just make sure you have a healthy baseline of information so that you can recognize misinformation when it comes your way. Okay.
Okay. Thank you so much. Thank
You're
you. It was
You're
very
welcome.
helpful.
Wonderful.
All right.
All right. Have a good rest of your training.
All right. Thank you so much.
Bye-bye.
Bye.